chronic pain is, I mean, it's universal. But getting good treatment for it, that's anything but.
Exactly. We have clinical guidelines that say, you need structured physiotherapy, you need exercise, psychological support,
Gold standard.
the gold standard.
Yeah.
But what do you do when you live somewhere and those services they don't exist?
And that's the reality for millions, right? Especially in low and middle income countries.
You have huge geographic barriers, the cost, a serious lack of trained professionals. It means that best practice care is just completely out of reach. So the big promise was, well, the internet, digital programs.
Okay, so that brings us to the mission for this deep dive. It's not just can we do digital health, but is it actually worth it? I mean, how do these really elaborate, expensive programs stack up against just giving people good information for free?
And that's the paradox we're digging into today. We're looking at a paper from 2025 by Sarah Giotto and colleagues on the ReabilitaDOR trial in Brazil.
And the paradox is what?
Well, they tested this complex coach digital program against a simple online booklet. And the complex program, it just wasn't clinically better,
Right.
but it was somehow the more sustainable, economically smart choice. And we need to figure out how both of those things can be true at the same time.
That is the ultimate twist. Okay, let's get into the setup. This was a superiority randomized controlled trial.
Right, which means they went in fully expecting their big intervention to, clearly win.
And the focus was on people in Brazil with chronic musculoskeletal pain. So pain lasting more than 12 weeks and at an intensity of at least 3 out of 11.
Yep. They had 162 people total, split them pretty evenly, 83 into the main program, 79 into the control group. And the key thing is, at baseline, the groups were basically identical. Same age, gender mix, pain levels, function. It sets the stage for a really clean comparison.
Okay, so before we get to the results, we have to really appreciate the difference between the two interventions here. You described it before we started as a Ferrari versus like a really good user manual.
That's a great way to put it. Let's start with the Ferrari, the ReabilitaDOR program.
What did that involve?
It was an 8-week, asynchronous, internet-based program. The core of it was pain education, so 8 animated videos covering really important topics.
Like what kind of topics?
Things like pain neuroscience, helping you understand that pain doesn't always equal tissue damage, acceptance strategies, sleep hygiene, and of course, a very structured exercise program.
But the really expensive part, the thing that made this the Ferrari, was the human element, right?
Exactly. That was the weekly health coaching. Every single person in that group had a one-on-one session with a real physiotherapist remotely every week.
So it's not an algorithm, it's a person.
A real person, personalizing the plan, answering questions, add in weekly motivational texts, and you're looking at a serious investment of professional time.
Okay, so that's the $81 program. Now what about the control group, the user manual?
The control group got what the researchers called a minimal digital intervention. Basically, it's what passes for the standard of care in a lot of these places where you just can't get to a physio.
So just information.
A really good, comprehensive online booklet. It covered self-management for chronic pain, healthy lifestyle stuff, how to be more physically active. All the knowledge was there.
But no hand-holding.
Pretty much. They got the same weekly motivational texts, but their only human contact was one single check-in call at week 4.
Just to make sure they were still in the trial.
Yeah, basically to make sure they could access the booklet and hadn't dropped out. So the comparison is perfect. Is all that weekly coaching and fancy video production worth it over a really well-made PDF that costs less than $10 to distribute?
And the main thing they were looking for was a drop in pain intensity at 8 weeks. But they also tracked things like function, quality of life, anxiety, for a full year.
A full year. It's a very comprehensive design. And the expectation, of course, was that all that coaching in the ReabilitaDOR group would lead to a much bigger drop in pain.
Okay, so let's get to it. The clinical results. This is where the first surprise lands. After all that effort, the physio time, the videos, what happened?
It was a statistical wash, just flat. For the main outcome, pain intensity at 8 weeks, there was no statistically significant difference between the two groups.
None.
None.
Yeah.
The mean difference was negative 0.74 points on that 11-point scale.
Okay, so a number like minus 0.74, it's small. How small is it really in a clinical sense? What would a doctor actually care about?
That is the critical question. In chronic pain research, we talk about the minimal clinically important difference, or MCID. And the consensus is you need to see about a 2-point reduction for it to be considered meaningful.
A 2-point difference between the groups.
Between the groups, yes.
Yeah.
If your big, expensive program doesn't beat the cheap one by at least 2 points, most clinicians are just not going to change what they're doing.
So they didn't just fail to prove superiority. The effect they did see was, for all intents and purposes, clinically insignificant.
That's the hard truth of the clinical side. The intensive program failed its primary mission.
Oh.
And that pattern, it just held up across almost everything else for the whole year.
Wow.
Function, quality of life, anxiety, no significant difference at 6 months or 12 months. The booklet was basically giving people 90% of the benefit for a fraction of the cost.
Yes. So why, I mean, did the authors have a theory? Was the coaching just not very good, or is the booklet just that good?
They seem to lean towards the booklet just being really, really effective. Think about it. For people with chronic pain who've had very little guidance, just getting clear, high-quality education on pain neuroscience and being encouraged to move safely. That's huge.
That alone can make a big difference.
It drives the bulk of the initial improvement. The weekly coaching might have helped with, say, adherence, but it was just adding marginal gains on top of a very powerful baseline effect from the education.
But wait, you mentioned a weird statistical finding, something about self-efficacy.
Ah, yes, that was the one outlier. At the 12-month follow-up, self-efficacy, so your confidence in managing your own condition, was actually statistically better in the control group.
The booklet group felt more confident. How is that possible?
Well, the authors were very cautious here. They think it's likely what we call a type-I error.
A false positive.
Exactly. When you test for so many different outcomes, you increase the odds of finding something significant just by pure chance. It looks like a real effect, but it's probably just a statistical ghost.
So clinically, the conclusion is pretty blunt. Save your money, give everyone the booklet.
That's what you'd think. But then we get to the second part of the study, the economics. And this is where everything gets turned on its head.
Okay, so if they're clinically equal, cost is everything.
Right. And at first glance, the story is simple. The ReabilitaDOR program cost $81 per patient.
And the booklet?
Just under 10. $9.70. So you look at that and you think, why would I ever spend 8 times more for the same result? It seems wasteful.
But they didn't just look at the program cost.
No, and this is the key. They did a full societal cost analysis over 12 months. They tracked everything: medication costs, doctor visits, even lost wages from people missing work.
And what did they find?
This is the core discovery. When you looked at the total cost to society over a full year, the expensive ReabilitaDOR group was actually associated with an average cost saving of over $200.
Wait, say that again? The more expensive program saved money.
Saved $209.40 per patient compared to the control group.
Yeah.
The upfront cost was higher, but it generated massive downstream savings for the healthcare system and society.
That completely flips the script. How did that play out in the cost-effectiveness analysis?
Well, for the outcome of pain intensity, ReabilitaDOR was labeled a dominant intervention.
And dominant in health economics is like the holy grail, right?
It's the holy grail. It means your program is both less costly overall and more effective than the alternative.
But hang on. We just established the effectiveness difference was tiny and not statistically significant. How can it be more effective?
That's a great question. It's because even a tiny, non-significant clinical edge, when combined with huge cost savings, can make for a powerful economic argument. The model they used, the ICER, showed that the program had a 98% probability of being cost-effective for pain reduction.
So it might not have been a clinical home run, but it was an economic grand slam.
For pain intensity, yes, it was effective enough to trigger these huge economic efficiencies that the simple booklet just couldn't.
But what about the other big metric, quality-adjusted life years, QALYs? That looks at overall well-being.
And this is where the picture gets a bit more complicated. When they used QALYs as the outcome, ReabilitaDOR was still less costly, but it was now judged to be slightly less effective than the booklet.
Less effective on overall quality of life.
Just slightly. A mean difference of negative 0.001 QALYs. Basically a tie. But that slight dip was enough to really weaken the economic case.
So what did that do to the probability of it being cost-effective?
It tanked. It dropped from 98% down to just 63%. Still potentially worth it, but no longer the obvious slam dunk it was when you only focused on pain.
So the coaching was really good at driving down pain and its related costs, but maybe not as good at improving, say, mood or overall function compared to just good education.
That seems to be the implication. The engagement was very targeted at pain self-management, and that's where the economic benefit showed up.
Let's talk about where those savings came from. if it wasn't travel costs, since both were remote.
Right, and it was during COVID lockdown, so travel was zero for everyone. The savings had to be coming from downstream.
Meaning people in the coach group just used less healthcare later on.
Exactly. Fewer doctor visits, maybe fewer trips to specialists, potentially lower medication costs, and fewer days off work. That sustained weekly engagement likely gave them the skills and confidence to manage flare-ups on their own, instead of running to the doctor every time. The booklet gave them the knowledge, but the coaching gave them the practice.
We have to talk about the elephant in the room, though. The study was run during the height of the COVID-19 pandemic in Brazil.
Yes. And the methodological hit was catastrophic, really.
How bad was it?
They had massive loss to follow-up. At the 12-month mark, they had lost 40% of their participants for the pain outcome. And for the societal cost data, the basis of that whole economic argument, they lost 52%.
Over half their data was gone.
You lose more than half your participants. It seriously undermines how much you can generalize the findings. People were getting sick, they were hospitalized, dealing with huge mental and financial stress.
So we have to take the economic findings with a huge grain of salt.
A huge grain of salt. The authors used advanced statistical methods to try and account for the missing data, but you just can't perfectly fix a 52% dropout rate.
Okay. Despite that massive caveat, were there any strengths to the study design?
Oh, absolutely. That 12-month time horizon is a huge strength. Most of these digital health studies only last a few weeks. And the way they collected cost data using prospective online diaries was excellent. It reduces the bias you get when you ask someone to remember their expenses from a year ago.
So putting it all together, what's the big takeaway here, especially for other countries with similar resource challenges?
It provides really valuable, rare evidence from a middle-income country. It shows that a high-touch digital program like this is feasible, people will do it, and it can be economically smart for pain reduction, even if it doesn't blow basic education out of the water clinically.
So it gives policymakers a real data-driven option where before they might have had nothing. It's an efficiency tool.
It's an efficiency tool. It's not a magic bullet. And the authors are clear. Future work needs to figure out who benefits most from this, and critically, how do you stop half your participants from dropping out over the year?
So let's circle back to that paradox we started with. The coach program wasn't clinically superior to the simple booklet.
A wash on most metrics.
But because it drove down those other societal costs, fewer doctor visits, less medication, it ended up being the economically dominant choice specifically for pain reduction. You'd completely miss that if you only looked at the clinical trial's main result.
And that's the key lesson here. An intervention doesn't have to be dramatically better clinically to be the right choice. In a resource-strapped system, if your program saves a ton of money downstream, even with just modest clinical gains, it might be the most logical and sustainable path forward.
Okay, so here's a final thought for you to chew on. The program had weekly coaching, but still wasn't clinically superior. What if they'd amped it up even more? Made the coaching mandatory, more frequent, maybe added group sessions? Could that have pushed them over the line to get a clinically significant result? And if it did, would the extra cost have destroyed the economic advantage they had?
That's the million-dollar question, isn't it? Chasing that last little bit of clinical benefit might have actually made the program less sustainable. Something to think about.